Okay. So what I'll do is if anyone else comes along, I'll let them in as we go. So thank you for signing up. So as we said, this is the third in the series of kind of different foundation jobs and all the tips and tricks we can get. So today we're going to be looking at MaxFax or oral and maxillofacial surgery. And we're really lucky to have Dr. Robyn Westerman with us. So a little bit about Robyn. So if you go to the next slide for me. Thanks. So Robyn's just finishing FY2 and congrats, moving on to be a junior clinical fellow in burns and plastic surgery, which is, I'm pretty sure, what you're interested in, isn't it, Dr. Westerman? Completed MRCS and has done a rotation in MaxFax, so she knows all the tips and tricks, as well as anything cardiology, upper GI, major trauma, GP and acute medicine. So if you have questions related to those at the end, feel free to ask away. I'm sure she's more than willing to help out. As always, a bit more about Medics&Me. So Medics&Me, obviously, we're a nationwide charity. We look at supporting not just aspiring medics, but also current medical students and past medical students, so current doctors. So we have lots of teaching opportunities, and we'd love for everyone to get involved if you're interested. There's plenty of opportunities to get involved with QI and research, which, as you're going into foundation years, is really important. You have to complete a QI project, and getting some experience with us, and kind of we run teaching series along with Tipsy QI about how to run QI. We've got a careers blog, so go and check that out, and you could even be a mentor if that's something that you're interested in. And on that note, I will let Dr. Westerman take it away.
Thanks, Rhiannon. Thank you for joining, guys. Hopefully I shouldn't keep you for too long, but I'm more than happy to answer any questions along the way. Just put your hand up or pop a message in the chat. Because there's just only a few of us, it'd probably be better if you could just shout out as we go. And then, yeah, like Rhiannon said, I have done other rotations. So if you do have any of those and have any questions about them, then happy to answer them. But main focus will be on foundation, so F1, F2 job in MaxFax. So what we're going to be covering today is the expectations of an F1 or an SHO on the job. I did MaxFax as an F2. I think on the whole, across the UK, it's probably more focused to an F2 SHO role, just because it is quite a specialist, and you do have more responsibilities in terms of practical procedures and things. So we'll cover some history taking and clerking, some common pathologies, emergencies, a typical day, week in the life, the ward round, some of the jobs that you'll have to undertake, so investigations, procedures and skills, and when you're holding the bleep, so when you're on call, and then we'll go over some opportunities in portfolio building, your well-being, and then some general top tips. So diving into the expectations of an F1 SHO, like I said, it's probably more so going to be an F2 SHO, but if you are an F1, then obviously the expectations will be a little bit less, because you're brand new to being a doctor, so they're not going to expect you to have all the skills and things necessary of an SHO. But the general core responsibilities is you complete a daily ward round with the consultant or a registrar and the rest of your team for all the inpatients of MaxFax. The inpatients will include post-op patients, so post-op cancer patients who have undergone major head and neck reconstruction, trauma patients, some dental, like post-op dental patients as well. If you're on call, you'll be clerking in your referrals from A&E, from general dental practices, from GPs or from other wards. You'll also hopefully have the opportunity to assist in theatre. So I had quite a lot of opportunity to assist. I had specific theatre days, but even when I was on the wards, I was more than welcome to go into theatre if I'd completed my jobs. So then for the post-op patients, you'll have all the jobs and things to do for the post-op patients. there tends to be a same day emergency clinic. So I'm currently based in Royal Stoke Hospital in the Midlands, but I think most centres have like a same day assessment clinic, if they have the capacity to have inpatients. So um, you could potentially be covering the clinic, and I can go into a bit more about what sort of things come up in clinic. Um, Again, assessing post-op patients, that includes when they have become unwell, or something has changed in their management, or the nurses have a query about either their feeding post-op, and things like that. Practical procedures, so you will get a lot of opportunity to practice your suturing, your abscess drainage of intraoral abscesses, and facial swellings as well. Another big responsibility is organising the emergency theatres. So when I was an F2 like SHO, I quite a lot of my role was organising, especially if I was on call, was to go and liaise with the emergency theatres, book patients in, make sure that you're scoring them as per the emergency theatre prioritisation, liaising with the theatre coordinators, the anaesthetists, things like that. So obviously, you know that a big part of the job is communication and escalating to seniors early, because it is such a specialist job. There's a lot of things, particularly because you need to have a dental degree to become a registrar. There's a lot of things, particularly the dental side of things, that I didn't know when I started, and they were the main things that I would have to escalate and ask a lot about, because we're unfamiliar with the anatomy. And same vice versa, if you've done dentistry and you've not done medicine, you've got a MaxFax job, you might not be so confident in the medical side of things. So you will have hopefully a couple of registrars that are dual trained, so we'll be able to give you advice on both the medicine and the dental side of things. Clearly handing over at the end of the shift. Realistic expectations. So, like I said, you're not expected to know everything on day one. I definitely didn't. It was a big learning curve, but I learned a lot, and I felt quite confident at the end of the rotation that I could manage things safely. So, just a bit about clerking and history taking. Again, it's quite specific in MaxFax, the type of history that you take. And this will obviously depend on the presentation that the patient's coming in with. So if they are, and I'll go on to some of the common pathologies, but if you have a patient that's coming with a trauma, you need to know what the mechanism of the trauma was and when the trauma happened, because that will then tie in with, well, what if it's a bony injury, has the bone, what's the degree of healing that's happened, etc., etc. You want to know their dental history. This doesn't have to be a complete dental history of every dental appointment that they've been to or every dental procedure that they've had, but it's particularly relevant in the context of facial swellings, if they've had a recent procedure, so a root canal or a filling or something like that. Then that all ties in and is really important in the context of swellings. So obviously where they've got pain, where they first noticed the swelling, how long's the swelling been there, has it gotten worse, has it changed? Trismus is a term for mouth opening and whether it's restricted, and we'll go on to later how you can examine for trismus, and if the patient feels like they've got any loose teeth. Another aspect which is important in trauma is any visual changes. So this is particularly in the context if we're considering if they've got an infraorbital fracture, or an orbital wall fracture. And then any systemic symptoms. So this is in the context of a facial swelling. So if they've had any fever, if they're flagging for sepsis, etc. Obviously, when you're taking a history, you need to document properly, particularly for MaxFax when you're covering the face. If there's any like lacerations or injuries that you can see, then it can be used for you. It's quite a different skill to maybe what you've had before with documenting, but documenting precisely the anatomical areas that are involved in a laceration or any sort of injury that involves the face. It's really useful for anyone reading where it is, how big it is, how deep it is, and if there's any important structures involved. And if you're able to take photographs, that's great because your registrar won't always be with you. So it's quite good to if you're able to take photographs, obviously with consent, then you can go and show them and just ask for some advice on how you should be approaching it, how you should be closing lacerations. So moving on to examination, this is a super important skill that some of it you'll already be able to do, and some of it is just takes a bit of getting used to. But pretty much every examination is the same, with just a few added tweaks depending on the presentation that they've come in with. So I've split this up into trauma and facial swelling. So in the context of trauma, similarly to any like limb injury, you want to approach it by a look, feel, and move approach. So initially, you want to look at the patient. Is there any obvious deformities, any lacerations, grazes, any tissue, like soft tissue loss, skin loss? Can you see like muscle or fat that's exposed? You want to examine the cranial nerve, especially cranial nerve 7, so the facial nerve, because the majority of facial injuries are around like this part of the face. So you want to examine the motor function of the facial nerve and then the sensory function as well. That can give you an indication as to whether they've got a fracture, so a facial fracture, or whether they've got some sort of injury, which is you can by your examination of the facial nerve, you can then try and figure out where that's like internally is impacted. You want to be looking at their occlusion. So I'm going to be using my hands and pointing to my face a lot because I find it a bit easier to explain. But their occlusion is what their bite is like. So you want the patient, so you can always put your hands either side of where their like TMJ joint is, and ask them to close their mouth and put their teeth together. So put their back teeth together and ask them whether that feels normal for them or whether it feels off and how it feels off for them. Is it to one side? Is it more protruded? Is it more retracted? This is particularly important when you're thinking about mandible fractures and maxillary fractures. Your bite is held together by your mandible and your maxilla. So if you've got a fracture which is displaced, then that can affect your bite. Again, mouth opening, whether this is restricted or not, and sensation. So sensation of cranial nerve 5, lower border of the lip here as well. Next, moving on to, and I've got a slide on how you can examine this as well. So if you're thinking they've got what we call a midfacial fracture, which includes the maxilla and the zygomatic bones, you want to test whether the maxilla is mobile, and I'll go on to that on the next slide. So that's the test whether there's any instability of the midface. So what can happen if you fractured your maxilla is that depending on how you've fractured it and what other bones are involved. So your maxilla is held together by your zygoma and your infraorbital rim as well, which is what your orbit sits in. That can become unstable if there's multiple fractures. So you can effectively have almost the midsection of your face is floating. Visual acuity and eye signs, if you're thinking that there's any orbital involvement, so you want to just test, so using the H test, ask them to cover each eye, and you could do like visual fields, and also the movements of the eye as well. So you want to assess the movements of the eye and if there's any restriction or any pain in particular movements, and we'll go on to that a bit more. So you're palpating the bony margin, so you want to palpate all around the mandible if there's any pain, if there's any step deformities, so if you can physically feel that there's a step in the bone. Similarly with the infraorbital rim, you can palpate underneath the eye quite firmly, but you can, if a patient has fractured the infraorbital wall, then you depending on how severe the fracture is, you can sometimes feel a step in the bone beneath the eye. Again, any loose or missing teeth, so always look in the mouth and make sure you've looked thoroughly in the mouth. And for any fragments, so if there is missing teeth, then where are those teeth? As the patient know where they are? Have they accidentally swallowed it? So then you'd have to consider things like doing a chest x-ray to see where the tooth is if they've lost it somewhere. Facial swelling. So facial swelling can be really dangerous, and your examination will guide how severe the facial swelling is. So things that you want to be asking yourself during your examination is, depending on where the facial swelling is, so I've got some images of different types of facial swellings, but facial swellings can be intraorally, so inside the mouth. I won't go too much into detail of the anatomy inside the mouth, but it can be just a buccal swelling, so that is where your gum is. So it might just be inside the mouth, and there might not be any swelling visible externally. They may have a swelling over their cheek area, and that could indicate that they've got a submasseteric abscess, so that is beneath the masseter muscle. They could have a submandibular swelling, a submental swelling, and they could also have some swelling beneath their tongue. So you want to know where the swelling is. Does it cross different areas of the face? So all of these areas in the face are pockets where pus can accumulate, and it can travel across different spaces in the face if it wants to progress. So when you're examining for facial swelling, is the lower border of the mandible palpable? So you should be able to feel the mandible. It's a hard bone, obviously. If you can't, then that's a sign that it's quite a severe infection or abscess. If they have a submental swelling, does it cross the midline of your chin? That's another indication that it's progressing quite quickly. The character of the swelling, is it soft, is it fluctuant, or is it really firm? Soft and fluctuant is more reassuring. A firm swelling is more severe. One thing that you always need to examine for is floor of mouth swelling. Now, you may have an indication when you go to see a patient that their mouth, they may be sat forward, drooling a little bit, mouth is open, and tongue, you can see their tongue sat quite highly. That could indicate that they've got floor of mouth swelling, which is an emergency, and I'll go on to explain why. So how to examine floor of mouth swelling is you get the patient to open their mouth, lift their tongue to the roof of their mouth, and you have to palpate underneath their tongue on the floor of the mouth. So along the hard palate of the floor of the mouth. If that's raised, firm, like I said, the patient's drooling, then you need to escalate this straight away. It's an emergency. It could mean that the patient's airway is compromised, and I'll go on to explain a bit more about that. Look inside the mouth. Is there any pus draining from inside the oral cavity? So you may see some pus draining from the like lingual aspect of the mouth, so like the cheek or the buccal space, which is where the gums are. We've gone over trismus, so always examine trismus and mouth opening. I'll go on to the next slide. I'll explain how you examine for that. If they do have trismus, so reduced mouth opening, then that indicates that it's a more severe infection and abscess, and that could lead to airway compromise. Again, if they've got any systemic features, any skin changes, so Sometimes patients will have a facial swelling, but actually it might be more something like a cellulitis or a sebaceous cyst. So just to differentiate between different swellings. So here are some images. Hopefully you can see my pointer here. This is how you examine for trismus. So you ask the patient to open their mouth. You place however many fingers that you can fit into their mouth horizontally. Trismus tends to be if you can only fit one finger or you can't fit any fingers in the mouth because the jaw is that restricted, that's classed as trismus. So if you've got 2, 3 more, then that's not trismus and that's okay. The reason why this happens, trismus, is because when you have an abscess that's within the spaces in the face, so submasseteric. So if you're thinking about submasseteric, that's below the masseter muscle. The masseter helps to open and close the jaw. If you have infection there, which is then restricting your masseter muscle and the muscle is contracted, then you're not able to open your mouth. Similarly, with other facial space infections, the muscles become inflamed and tightened, and so the patient's unable to open their mouth. And like I said, that indicates more severe infection. This next image here is how we examine for a mobile maxilla. So you ask the patient to just relax with their head still. You place your fingers and thumb over the teeth and in the soft palate, and you just try and wiggle it like that. Obviously, normal circumstances, it shouldn't move, but if you have a mobile maxilla, then you will easily be able to move it. Obviously, you do this very gently. This image here is how you can assess for when you're assessing for mandible fractures. So again, if a patient has a severely displaced mandible fracture, and mandible fractures tend to, because of the way the bone is anchored, they tend to break in more than one place. So if you've got breaks in more than one place, that can lead to an unstable mandible, and you may be able to move it as well. This image here is what floor of mouth swelling can look like. So as you can see, patient's got their mouth open, the tongue appears raised, and here you can see that that's the floor of the mouth, which usually you can't see in a person. So this is all inflamed and elevated, and that's an emergency. Here in this bottom left is this, you can see this patient looks like a child has got an avulsed tooth. So their tooth is completely avulsed. And we can go on to a bit about how we manage that. This here is a sign in the middle of enophthalmos. So when the eyeball has sunken down in the socket. So you can see in this gentleman's left eye, the eyeball is sunken in comparison to the right. This can happen when if a patient has an inferior orbital wall fracture, if the fat and the muscles, the extraocular muscles and fat drop into the fracture. So imagine you'll all probably all be aware of this, but your eyeball sits in a box. If the bottom part of that box splits and breaks, fractures, then the fat and the muscles can sink down and pulling the eyeball down with it. So that's an important sign to look out for. This in the bottom right is what a submandibular, and it looks like submental swelling looks like. Obviously, I've not got the patient in front of me, but this looks quite firm. And so this is involving the submandibular space here, and it looks like it's crossing over to the submental space. Is everyone happy with history and examination? Any questions about that so far? If not, I'll move on. Great, thank you. Some common pathologies that you are likely to come across if you have a job in a busy tertiary centre. Infection. So we've spoken a bit about dental abscesses. So this can be buccal, submandibular, submental, and submasseteric, which we've gone through already, the different spaces of the face. Now, when I've been referring to floor of mouth swelling, I'm referring to something called Ludwig's angina, which is a very severe infection of the facial spaces. And this is an emergency. A patient could lose their airway very quickly. So Ludwig's angina is classified as multiple facial space infections on both sides. So you need to have really submandibular, submental on one side, submental on the other side, and possibly submandibular on the other side, or submasseteric. But it involves the majority of the facial spaces, and that's because the infection and the pus and things have travelled. That's when you need to be escalating to your senior as soon as. Sometimes these patients may not even get a CT scan. They need to be rushed to theatre straight away for probably intubation and ITU until the infection settles down. This picture in the top here is another example of what Ludwig's can look like. Tongues raised, floor of mouth swollen, patient can't close their mouth. Another thing that may be admitted under MaxFax or ENT is parotitis. So parotitis typically comes with a really painful swelling over the parotid gland. You can differentiate it quite easily from a dental abscess, but you'd usually get a CT to confirm. Another thing that I forgot to mention in examination, particularly in facial swellings and a suspected dental abscess, is palpating the teeth. So if you have a left-sided facial swelling, say for example it's possibly submasseteric or buccal, so intraorally, typically it makes sense. Your upper teeth are most likely to spread to this area of your face. Your lower teeth are most likely to spread to submandibular and submental. So you want to, with your finger, press on each of the teeth within that area, and the patient will be able to tell you which one's most painful. That is when we can determine, you're going to get a CT most likely as well, but you can determine which tooth is the culprit, because when these patients go to theatre to have a drainage of the abscess, the tooth that's the most likely culprit, which is rotten and decayed, which is causing that local infection, will be removed. Sometimes this is multiple teeth. Common pathologies in trauma, so mandible fractures, zygomatic fractures. You can have zygomatic complexes as well, which involve the maxilla. Orbital fractures, which we've spoken a bit about. Lefort fractures is how we classify maxillary fractures. So this image here is type 1, 2, 3 of maxillary fractures. These are called Lefort type 1, type 2, type 3 fractures. So type 1 is just isolated to the maxilla. It's a horizontal fracture across the maxilla. Type 2 involves the whole of the maxilla, but can extend up through the infraorbital rim, involve some of the nasal bones. And type 3 is when this is called like a pyramid. So this is more of like a triangular, and this is called a transverse fracture. So you can see that it involves the whole maxilla. It ascends up through the mid part of the orbital wall, crossing over the nasal arch, and then back down. So it involves both sides of the face, and so it's a bit difficult to appreciate, but this whole maxillary zygomatic complex area is now completely detached from the face. So it's just floating underneath the skin, essentially. Nasal fractures sometimes will come to MaxFax, sometimes come to ENT. Tooth avulsions, animal bites of the face, animal scratches. Other pathologies that you may see is salivary gland disease. So again, facial swellings can be caused by salivary duct stones, which are blocking the salivary ducts and causing a swelling. Head and neck cancers, so oral, tongue, base of tongue, mandible. You can get malignancies that involve the mandible. TMJ dysfunction and dislocation. This is usually seen in clinic, so we don't usually dislocations is something that we see in ED, and there's certain maneuvers that you can do to pop the jaw back into its place. But TMJ dysfunction tends to be seen in clinic by the regis or the consultants. Osteoradionecrosis in cancer patients you can see as well, and socket bleeds. So if someone's undergone a wisdom tooth extraction or any other tooth extraction, they may be on an anticoagulant, they've come in and they're pouring out blood and it won't stop. So that's something that will come into ED sometimes, and we have to use gauze or use some tranexamic acid to try and stop the bleeding. If that doesn't work, then we may need to suture the socket shut. So these other images that I've got on the right, this is a facial bone CT, which has been 3D extrapolated, and you can see that there's a fracture there through the body, and can't see any other. There's possible crack there. I can't see around the other side. And this image at the bottom is of a facial bone CT, but a like sagittal view, and this represents an infraorbital fracture. So as I was mentioning about how this person's got an infraorbital fracture, which has completely disrupted the floor of the orbit. And you can see that this is probably fat. And here, these are the extraocular muscles that you can see in a slightly lighter grey. So some of the extraocular muscles, so the inferior ocular muscles, are involved here. So the patient may have some enophthalmos. They may have some restricted eye movements looking up and possibly laterally or medially. It depends which muscles are involved, but that's what it will look like on a CT.
Just a quick question in the chat, Robyn.
Oh, sorry, I can't see.
Yeah. I know, that's why I was waiting for you to finish this slide. Yeah. It's related to this slide, which is about the floor of mouth swelling. So is it an emergency because of airway compromise, or is it a sign of something underlying that's serious?
It's more so for airway compromise. So when you have an infection which is this severe that is causing the floor of the mouth to raise, that could indicate, because we can't see the airway, that could indicate that if the infection has crossed the midline, then you're anticipating that the infection and the swelling and the edema is impending on the airway. So it's more so airway compromise. So in some patients that may have floor of mouth swelling, but they're still swallowing okay, they're still talking okay, you may have time to get a CT scan to check if the airway is patent or not, and that may give you a little bit of time to get them to theatre. But in some patients where it's quite obvious that the airways obstructed, then they would be going straight to emergency theatre for intubation.
Perfect, thanks. I think that explains it really
well. So moving on. Must not miss emergencies. So we've kind of spoken about this already. So Ludwig's, which is again what we've explained, a spreading neck space infection. So it's involving different spaces in the face, along with crossing into the neck. A post-operative neck hematoma. So these are all airway emergencies. So if a patient's had head and neck surgery and then they've got a hematoma in the neck, you need to take that seriously. You may need to get a CT scan to check if the airway is patent or not. These patients might not always need to go back to theatre as an emergency, but you need to escalate and take these very seriously. Mandible fractures with neck swelling. So again, the reason for this is when you have a mandible fracture, the edema and the swelling because of the fracture, if it's that large, it can again cause airway obstruction and tracheostomy bleeding. So any bleeding from a trachea is an emergency. You may need to go back to theatre. Vision emergencies, so orbital compartment syndrome. So if a patient's had trauma and they've got extensive facial fractures involving the orbit, it can cause bleeding behind the eye. Now, this is an emergency because if you've got bleed, again, your eyeball sits within a closed space. So if you've got, similarly to the brain, it's in a fixed box. It's got the swelling has nowhere to go. If you have bleeding behind the eye, it can compress on the optic nerve and you could lose your vision. So these patients need a lateral canthotomy, which is essentially an incision, lateral canthotomy, so an incision in the lateral part of the eye to release the pressure. Other red flags, so base of skull fractures or any CSF leaks from the nose, ears, they're emergencies. Necrotizing soft tissue infections, so necrotizing fasciitis of the face. It's not a typical area that you get neck fash, but it's a possibility. And obviously any septic patients. So just a week in the life, I've already mentioned some of this. So my weeks would be, I'd maybe have 1 week where I was on normal 8 till 4 days, and this would involve me attending the ward rounds, maybe going to theatres, to the emergency theatre lists, and then I would have weekends on call, weekdays on call, so this would be 8 till 8:30, and then nights on call as well. Your nights, your registrar is usually non-resident, so they tend to be at home or off-site. So it's usually just an SHO covering the hospital and any referrals from different hospitals. You'll attend MDTs and trauma meetings, probably with other specialties as well. If they've got extensive facial fractures, they may have other fractures elsewhere, and this may require organisation with other surgical specialties to decide, well, okay, they've got a femoral fracture and they've got a mandible fracture, can we operate on them at the same time? Outpatient clinics, so I didn't like shadow many outpatient clinics, but it was useful to be around, and whilst consultants and registrars are talking about patients and when they first come to clinic, and hopefully you'll have some teaching along the way. So what to do during the ward round, so before, during, and after. So just some basic things really. Before the round, so in my job, we didn't have a period where we would be able to review everything before we went to see the patients. What we had instead was a handover sheet that the night team would update with all the updated bloods, observations, medication changes, scan results. So then we would just go around with the sheet of paper. But what you can do before the round is from the handover from the night team, they will hopefully highlight anybody who's unwell and should be seen more urgently. During the round, they tend to be quite quick rounds. You don't tend to have too many inpatients. So what I try to do is note down jobs as the registrar or the consultants telling you what they would like. Try to do smaller jobs whilst as you're going. So things like prescribing, any pain relief, things like that. Make sure you're documenting. So this is in all surgical patients, but they may have drains. So in head and neck patients, they'll most likely have neck drains. They may have intraoral drains. So you want to document the drain output, how much it's been draining, what the consistency is, whether it's bloody, whether it's pus, things like that. And then flap monitoring, which is particularly important in the post-op oncology patients. So the flaps tend to be inside the mouth. So it may be they've got a flap on part to reconstruct part of their tongue. They may have a floor of mouth flap. They may have a mandible flap. And these flaps can be just skin and some muscle. They can include bone. So they tend to use part of the fibula to reconstruct the mandible if they've had to remove some of that in oncology surgery. So when you're monitoring flaps, you want to know what the colour looks like. Is it pale, which could indicate that there's not enough blood flow and the flap's dying, or is it purple? Purple indicates that the venous drainage from the flap is not good enough, and so the blood's accumulating in the flap like a bruise. Both of those scenarios, whether the flap's pale or purple, is something that you potentially the flap that it might be failing and it may need to go back to theatre. What the consistency of the flap is it soft, is it firm? And usually there'll be a Doppler, so attached internally to the flap that is put in during surgery. So the Doppler you turn on and it should have the sound of blood flow. After the round, any urgent jobs you want to do more promptly, prioritising well patients. Find out whether there's any MDTs coming up for the oncology patients and what the outcome of that was. Any discharge planning for patients. Create a good jobs list. This is pivotal in my eyes to whether you can remain organised and you can follow the progression of patients, and you can highlight things to your seniors that might not be right, and make sure you're delegating tasks among your team so you're splitting tasks evenly. And again, you'll probably have a mixture of dentists and medics in the team. So the medics tend to take more of the medical jobs or try and teach the dentists about it. And then the dentists tend to take more of the dental jobs. So try and split it up like that. Investigations that you may be requesting. So imaging, so an OPG. This is what an OPG looks like. You get these done at the dentist, but in MaxFax it's particularly important when you are thinking about mandible fractures. You can see both the condyles, which is important. Sometimes you can't see it very well in a CT scan, so you can see the condyles quite well. Condyle fractures can be quite hidden. You may get OPGs in facial swellings, and that's important for finding out which tooth is the culprit that's causing the infection. So there doesn't seem to be any infections brewing in this one, but infections tend to look like more of a black rim around the culprit tooth, and you may see some darkened area around that tooth, which is indicating that there's an abscess building there. CT scans, so any trauma patient, most trauma patients will get a CT facial bones. In my trust, if you requested a CT head, if you requested, a CT neck or a CT head, it wouldn't include the mandible. So facial bones CT does. Again, you want to be getting CT, sorry, that bit's cut off, but for any complex trauma patients or any suspected spreading infection. You may also request CT necks. So if you've got a facial swelling that's involving the neck, you want to get a CT head and neck, because again, the CT head won't come all the way down to the neck where you need to see. MRIs are useful in head and neck cancer staging. Bloods, it's all the routine sort of blood, CRP, white cells for infection. Surgical patients will always need to have a group and save and a cross-match pre-op. So if you're In theatre that day, you probably expected to go and help consent the patient, make sure that everything's ready, they've had a group and save cross-match. Hopefully this should have all been done in their pre-op assessment, but it's just to be aware of. And then when you're thinking about facial space infections, and intraoral infections, there may be pus there that you can swab. Same with drain sites, you can swab drain sites to see if it grows anything. And when patients go to theatre for drainage of abscesses, then most likely they'll have a swab taken. So it's your job to chase that up and see what the result is. So moving on to procedures and practical skills, some core skills, so taking bloods, inserting cannulas, simple wound closure and suturing. If you're on call as an F2 or an SHO, then a lot of your calls are for facial lacerations, lip lacerations. It will be your responsibility to close these. So I would advise if you're going into a job in MaxFax in F2 and you've got a surgical job in F1, try and get to theatre as much as you can, even though it's not the face. Just picking up your suturing skills is a massive help. You maybe, if you're competent to and you're confident, then you may be asked to incise and drain abscesses intraorally. So this here on the bottom is a buccal space infection. So you can see this is the gum, and you would numb the area with local anaesthetic and then just use a knife to slice that and let the pus drain. Splinting teeth, so this image at the top right, top here is what it looks like to splint teeth. You do this if patient has an avulsed tooth, so they've lost a tooth. What you would do is use some local anaesthetic to numb that tooth, pop the tooth back in to where it looks as best you can, it looks in the right place. Then you are using a wire which is malleable so you can mold it. You want to be splinting at least the two adjacent teeth to the tooth that's been avulsed, if not some more for the stability. This over the top of the teeth is composite, so you go and you take composite and you've got a UV light to set the composite. This is something I didn't know how to do before I started the job, and someone had to teach me how to do it. It's quite simple, but it's just a bit fiddly, so you get better at it the more times you do it. But it is useful the first couple of times you do it to take somebody else with you, preferably a dentist. Yeah, so local anaesthetic, how to use it, what local anaesthetic to use, where you want the blocks to go will depend on which part of the face you want to anaesthetise. And suture removal. This is more so in if you are involved in the clinics, so the same day kind of emergency clinic, or if people have booked somebody in a post, if somebody's had a facial laceration and we've stitched it and they're coming back in 7 to 10 days for suture removal. Skills that you can become more confident in throughout the rotation is putting on IMF wires or arch bars. This is in the context of if a mandible fracture doesn't need to have plating done, so it doesn't need to go to theatre for an ORIF, so open reduction internal fixation. Some mandible fractures may be managed with IMF wires, so you're wiring the jaw shut to keep it in place so that the fracture can heal. Airway assessment, so assessing the airway, we've already mentioned some ways that you can assess the airway. If the patient's talking to you, if they're not drooling, if the inside of the mouth doesn't look particularly swollen, if they're still drinking okay and eating and they don't feel like they're choking, that sort of thing. Inserting NGs for post-op patients. And then some more advanced suturing skills, so intraoral suturing. So this can be if you've got a bleeding socket and you need to suture the socket shut. If you're in theatre, try and get to theatre as much as you can. You can have the opportunity to take skin grafts, so full thickness or partial thickness skin grafts. It's most often full thickness skin grafts for oncology patients. and closing flap donor sites. So if they've taken a fibular flap, then you'll have the whole of the skin, the muscle, fat, and skin of the fibular site to close. If they've taken an ALT flap, so an anterior lateral thigh flap, that will need closing. And they take a while, but it's really good suturing practice. You may get the opportunity to extract some teeth, either if the patient is under GA or in clinics as well, under local anaesthetic. And tracheostomy care as well. The nurses tend to be really good at this, but it's useful to learn from the nurses how to suction trachees, what the different size trachees are. You'll pick this up on the job. There's so much to cover that I've tried to keep it succinct, but there's different trachea sizes. So when we're trying to wean somebody off a trachea, so we can eventually remove it if they're an oncology patient, they've had head and neck reconstruction. We tend to use different sizes, and we will the trachea initially will be open, so it'll be fully patent. But then as the patient begins to recover and the swelling reduces, then we can cap the trachea, see how they get on, see if they can breathe on their own, and then that's when we can start to remove the trachea. Any questions about that? Anything in the chat, Rhiannon?
Yeah, so thanks for going through this, Valerie. As well as getting into theatres, is there anything else we can do as an F1 to prep for being the MaxFax SHO? Also, do you know of any good resources for going over head and neck anatomy?
I think the main thing is just practicing your suturing skills, to be honest. It goes a long way if you can stitch. Because when you're on call in F2, you will be independently going to close facial lacerations, lip lacerations by yourself. So just being quite comfortable. You don't have to be super, super confident, but being quite comfortable in your basic suturing skills so that when you come to the job and there is maybe a complex facial laceration or a full thickness or it's involving important parts of the face aesthetically, that's when you can speak to your registrars about what different suturing techniques that you can use to make it look more aesthetic and it will heal better. Other than that, it's more so, again, you don't have to read loads and loads, but being a bit aware about intraoral anatomy, which is for medics, it's not something that we're taught, but knowing how to like number the teeth, it's quite simple once you've done it a few times. So they number the teeth, so upper 1, 2, 3, 4, 5, 6, 7, 8, and lower 1 to 8. Knowing that where your buccal side is, where your lingual side is. But again, all these terms you'll pick up and you just ask, remind me which part's buccal, which part's lingual. Anatomy, I just use things like teach me anatomy. I'm trying to think what else I maybe used. I'd just keep it quite like basic. So teach me anatomy. There's nothing that I would say that you need to like purchase any books or anything like that before you start, but just being familiar with the names of the facial bones, the names of the facial nerves, the basic things, some neck anatomy, which will come in handy if you're in theatre, particularly in the oncology patients. They dissect the lymph nodes from the different triangles of the neck. So if you're familiar with some of the terminology that they use, then you'll be able to ask questions whilst you're there. You said, oh, okay, so you said that was the inferior vena cava or like superior vena cava. Like, can you show me where that is? Oh, you said that was neck triangle like 1. Like, could you point out to me what the borders are so I can then visualize it? So if you know some of the names of things and roughly where things are, then that's when you can ask questions, and it makes it a better learning opportunity for you because then you've got a basic knowledge that then you can build on in theatres and things. Does that make sense?
Yeah, that was perfect. Thank you.
Okay, moving on then. So some operations. So this is elective day case operations that you may come across. Dental extractions and whole dental clearances, so removing all the teeth. Excision biopsies of oral and facial lesions. So these tend to be day case. So this is for patients that have been picked off that they may have some dysplastic looking cells intraorally or on the face that may need removing, and they may just require a simple closure, or they may require a bit of a local flap to cover that. Orthognathic surgery. So this is surgery for patients who have so like in this lady here, you can see that her mandible is more protruded, so she's got what we call an underbite. So this surgery involves so what they essentially do is they would break the mandible on both sides and then reposition it so that then she's got a more normal bite. Similarly, you can have a maxilla which is too far forwards or too far back. So you may need to fracture both the mandible and the maxilla and move both in line so that then the occlusion, the patient's occlusion to their bite is much better. It's for aesthetic reasons, but it's also for functional reasons as well. So they'll be able to eat better, be more comfortable eating and things like that. Salivary gland surgery. Some facial fractures that don't need to be repaired within the first few days. So this can be orbital floor fractures, zygomatic fractures, zygomatic maxillary complex fractures, so ZMC fractures. Often you tend to wait about 10 days to 2 weeks to repair these, to wait for the swelling to settle down, and then you can see how the fracture's misaligned better. So you tend to wait a couple of weeks to fix these. So they're kind of semi-elective operations. Parotidectomies for sometimes cancer will be semi-elective, but non-malignant parotidectomy, so removing the parotid gland, maybe partial parotidectomies or total. This can be for like benign tumors and things as well. And then dental implants. So you may get patients come in who have quite complex dental anatomy or need lots of implants. So you may see implants being done as well. Trauma and emergency surgeries. So open reduction, internal fixation of the mandible or zygomatic fractures. So these images here, you can see there's a fracture there through the body of the mandible. And this is plating that is used to reduce the fracture and fix it. Similarly, again, in this one, this is using a plate to repair this fracture here. And we use screws and plates. And this also shows actually here the IMF, what IMF looks like. So that's intermaxillary fixation. So that's when we want to keep the mandible and maxilla stable to allow for the fracture to heal. This can be used as well in condylar fractures. So sometimes condylar fractures don't need to be repaired with plating, or it's too difficult to get to. So IMF may be used to keep the jaw in place to allow for the condylar fractures to heal. So incision and drainage of facial space infections, orbital floor repair. So this is a model. There's different ways to approach this, but essentially you're finding the fracture. So this is an orbital floor, and you tend to put a mesh or a plate or a bit of kind of like plastic material to make sure that the fat and muscles of the extraocular don't sink back into the fracture. So you fix the fracture and then you place a plate or something. So head and neck reconstruction we've covered a little bit. Neck fascia, the face and neck obviously needs extensive debridement as an emergency. Sometimes facial lacerations can be really extensive and may take too long or are too traumatizing to keep the patient awake for it. So, and they sometimes require extensive washouts if it's really dirty wounds. So you would put them patients to sleep and gives you a bit more time and it's a bit more comfortable for everybody to repair those under GA. And then small children with lacerations, depends on the child whether they'll let you put in some local anaesthetic, same with the parents. And so some children, again, if you want to get the job done properly, even if it's only a really tiny laceration, you would put the children to sleep for that. Particularly if in lip lacerations. When you're on call and you're holding the bleep, how to approach things. So every call that you get, try to ask whoever's calling you, what's the patient, what the patient's like, are they stable, what's their news score, are they septic, do you think they're sick right now and you have to go and run, are they going to be sick fairly soon, or is this something routine that you can take a bit more time with? Ask if they've had any scan results or bloods done. If a patient has come in with a trauma, ED might have already done a CT facial bones. Same with a neck swelling or a facial swelling, they may have already done a CT head and neck. Escalate when there's a concern of airway or breathing, if there's any uncontrolled bleeding, if the patient's becoming drowsy. If you're unsure how to approach difficult lacerations, so sometimes patients will come in with half the face lacerated and it can be quite deep, then I'd feel like that is something that you should escalate to a senior. And if you feel uncomfortable with any practical skills that you've not done before, like I said, there's a lot of dental procedures and things that you may not have done before, so it's important to ask. Some practical tips. So it can be useful to document every call that you take, whether that's on a piece of paper or if you think it's you having to provide more input for the patient, then to document electronically or paper, whatever your hospital uses. Know who covers what overnight, so who your registrar is, who your consultant is, how to get hold of them, what different specialties cover as well. So sometimes specialties won't cover things overnight and then it comes to you and vice versa. So this is my little bag of things that I would carry with me on normal days, but also on calls. So I've got my bleep there. These are all sutures. I've got some needles there, some local anaesthetic, a pen torch. Yeah, that's pretty much all the things that I would carry. Some snacks. Sometimes you can be run off your feet and not have a chance to have your break. Know where this disposable suture kits are. So when you're going to repair a laceration, ours were in ED or theatres, and that's what we would use to repair laceration. So know where they are. Get friendly with the theatre coordinators. They will, if you're nice to them and respectful, they sometimes will bump your patients up the list and be a bit more forthcoming with where your patients are going to be, when your patients are going to be operated on. And the PDD team, the nurses in particular, were amazing with me, and they're incredible with children. And sometimes you need to hold children down in the kindest way you can, to try and clean things to let you be able to see wounds and things properly. But they're really amazing to get friendly with. Any questions?
Nothing in the chat, no.
Okay. Opportunities and portfolio building. So try and get in there early. If you're interested in MaxFax or any other surgical specialty, try and see if we've got any audits or QI projects going. If you come across any interesting cases, you could always discuss with a registrar or a consultant about whether it'd be worth trying to write that up as a presentation or a publication. if you're interested in surgery, try and get your surgical cases logged on your logbook, on your e-logbook. And if you get the chance, try and do a course or something. So I recently went on the basic surgical skills course at the Royal College of Surgeons in London, and I'd recommend it. It was really good fun. It was a 2-day course. You covered both basic and more advanced surgical skills, and it was a really fun day and really useful. Yeah, so try and get involved in whatever you can. It's a super fun specialty, and whether are interested in MaxFax or not, it's a rotation that I really enjoyed and are potentially considering it as a career. Your well-being, of course, I've just said about breaks, but try and get them when you can. Exception reporting any hours that you've overworked. You'll have an educational and clinical supervisor, so make sure that you're asking them for any help that you need. From my experience, the registrars were super helpful, and my dental colleagues that I had at the time were really helpful as well. And just ask. They know that it's a specialty that you won't have much exposure to, and it's quite niche. So they'll be happy to give you advice on anatomy and practical skills and things. Final advice, introduce yourself to the whole team. Dental nurses as well, they'll make your life either hell or they'll be lifesavers, depending on how nice you are to them. Keep a good jobs list. When you're going to theatres, go and introduce yourself to the scrub nurses, to the ODPs, to the different theatre staff. They again, if you're going to be left at the end of theatre to finish suturing, or sometimes a consultant might leave you depending on how competent you are, then they can get a bit frustrated if you're taking a long time. But if they know you and your friend, that you become friendly with them, they'll help you, and they'll guide you and tell you how to do things, teach you about the equipment, and they'll be super useful. So get them in your good books early. Read around your patients, and if you go into theatre, try and have a quick read of the case and what you might expect to happen, so you can ask some questions, and always be kind to yourself. Thank you so much for listening. This is a feedback form, and you'll receive a certificate, I hope.
You'll get slides. So
slides, you'll get the slides. You'll get the slides. Yeah.
Please fill it in.
Yeah, please fill in. I'm open to any questions about MaxFax or anything else, really.
Yeah, so we've got one about working in MaxFax so they've been told that the department that they work in like to get the F1s involved in the audits and quality improvement projects. Do you think there's any scope for imaging-based audits?
Yeah, I don't see why not. There's a lot of MaxFax will do a lot of imaging. So if that's something that, if you're thinking about radiology or something like that, then you could do it MaxFax themed kind of radiology sort of thing. Yeah, I don't see why. That's something that you can. This is the thing about rotational training, is that they know that you might not want to do that specialty, but there's hopefully people that can help guide you in the right direction for these things.
Perfect, thank you. Is there anything else? Just put it in the chat, guys. And if not, have a lovely evening. Thank you so much, Dr. Westerman. This has been an amazing talk.
Thank you. Thank you so much for staying on, guys. Appreciate it. Hope it was useful.
Okay. I think that's all the questions, so I will stop the recording.
Perfect. Thanks, Rhiannon.